Good morning. Thank you for joining us today. I'm Marie Ritardone, a program director at the NCI Center for Global Health. In 2021, in celebration of CGH's 10th anniversary, we launched the NCI Global Cancer Research and Control Seminar Series to feature talks by researchers and cancer control experts working in global oncology and provide opportunities for discussion and collaboration on impactful and innovative work addressing cancer morbidity and mortality worldwide. Today, in honor of Childhood Cancer Awareness Month, I'm delighted to welcome Drs. Asya Agulnik, Carlos Acuña, and Ginger McKay to present their work on implementation science to improve childhood cancer survival in low and middle income countries, discuss the challenge of treatment-related mortality in resource-limited settings, and explore the use of implementation science to improve childhood cancer survival in these settings. Dr. Asya Agulnik is an associate member in St. Jude's Children's Research Hospital in the Department of Global Pediatric Medicine, with a joint appointment in the Department of Pediatrics, Division of Critical Care. She's the director of the St. Jude's Global Critical Care Program. Dr. Agulnik obtained her undergraduate degree from Harvard University. She earned a Master of Public Health degree from the University of California, Berkeley, and obtained her medical degree from Stanford University School of Medicine. Dr. Agulnik completed her residency in pediatrics through the Boston Combined Residency Program and Pediatric Clinical Care Fellowship at Boston Children's Hospital. Dr. Agulnik is a clinical scientist with expertise in pediatric clinical research, critical care and research, focused on how to implement, scale up, and sustain interventions for children with cancer in resource-limited settings. He leads the Proyecto EVAT, a quality improvement collaborative in Latin America to support implementation of Pediatric Early Warning System, an intervention to improve early identification of clinical deterioration in hospitalized children with cancer. Dr. Carlos Acuña is a pediatric intensivist and chief of the Pediatric and Neonatal Intensive Care Unit at Luis Calvo Mackenna Hospital in Santiago, Chile, an associate professor of medicine in the Department of Pediatrics and Surgery at the University of Chile. Dr. Acuña is also a member of the steering committee EVAT program, Global Critical Care Medicine program at St. Jude's. Dr. Acuña obtained his undergraduate and medical degree from the University of Chile and completed his medical training in Pediatric Critical Care Fellowship at Le Bonheur Children's Medical Hospital in Memphis. Dr. Ginger McKay is assistant faculty in the Brown University School of Social Work at Washington University in St. Louis. Her research focuses on the dissemination and implementation of evidence-based practices, especially the sustainability and de-implementation of interventions. She does a membership of the leadership team for D&I research in the Institute of Clinical and Translational Sciences at Washington University, and the assistant director with research for the Center of Public Health and Brown School. Dr. Agulnik and Dr. McKay were recently awarded an R37 to study the sustainability of PEWS in resource-limited settings. Before turning the microphone over, I'd like to review a few logistics. First, please save your questions for the designated Q&A time immediately following the presentation. You may type your question in the chat box or use the raised hand feature found under reactions. Second, please note that today's presentation is being recorded and will be available on our cancer website at cancer.gov/globalhealth. Finally, you can find information about future presentations on our website and by following us on NCI Twitter at NCI Global Health. And now we'll begin our presentation. Welcome, Dr. Agulnik, Dr. Acuña, and Dr. McKay.
Thank you so much, Marie, and everyone for the invitation to speak here. I'm going to start with our introductions and then pass the microphone over to my colleagues for the talk. Just give me a second to get myself arranged here. As you heard, my name is Asya Agulnik. I'm a pediatric intensivist at St. Jude and director of our global critical care program, and I'm joined by Dr. Carlos Acuña and Dr. Virginia McKay. I wanted to start our talk on implementation science to improve childhood cancer survival in low middle income countries, just to review our disclosures. You heard that both Dr. McKay and I are funded by a recent NCI R37 with the work that we'll be describing in this talk. The pilot funding for this study and this work came from the St. Jude Washington University Implementation Science Collaborative. And some of the work we'll be presenting was previously funded by the Conquer Cancer Foundation, which was a Young Investigator Award that I held before this. So with that, I'm going to pass the microphone over to Dr. Acuña, and just tell me, Carlos, when you want me to advance your slides.
Okay, thank you, Asya. Good morning, and thank you for the invitation. So we know that the problem is we have disparity in childhood cancer outcome. We know that close to 90% of children with cancer live in low and middle income countries, with a 5-year survival lower than at 20%. And we know that 80% of children with cancer will survive in high income countries. We know also that treatment-related mortality in high income countries is approx 3 to 5%. However, in low and middle income countries, treatment-related mortality has been reported close to and up to 45% in children with cancer. Next, Asya, please. So in this systematic review and meta-analysis published on Lancet this year, we show that the treatment-related mortality was close to 7%, 6.8%, and that represents a third of death after starting treatment. Also, we were able to show that that was inversely related to the country income level, with a 14.2 in low income countries, with a 9.2 in lower middle income countries, and with a close to 5% in upper middle income countries. And that was higher among hematology malignancy. Next, please. When we talk about the causes of TRM, we know that there was a poor documentation of cause of death because it was a wild variability in definition of treatment-related mortality, and the quality of that report mortality was poor also. But among those with listed causes, which we were able to show that the almost 72% was due to sepsis or infection, 10.7% due to hemorrhage, and almost 5% due to metabolic causes. And if we saw the angiocorpore hematology malignancy versus CNS solid tumor and non-CNS solid tumor, the most of that TRM was in the hematology malignancy patients. Next, please. If we talk about change over time in TRM, if we saw the overall series, there was no change in TRM over time. But next, please, is if we compare upper middle versus lower and middle, there was some improvement in upper middle income country over the time. But unfortunately, there is no improvement among low income country and low and middle income country. So that what makes a widened disparity over time. So that is really, really, really bad. Next, please. Now, what are the challenges in TRM in low and middle income countries, especially in Latin America? Probably have to be with socio-demographic aspect. Latin America is a very heterogeneous region. Some aspect to highlight, there is a significant percentage of population that live below the poverty line, as you see in the graph in your right. Also, there is less access to education and health. So that is a part of the big issue and the challenge of TRM in Latin America. Also, cancer is often detected in late stages and with a higher rates of treatment abandonment and loss of follow-up in that patient. That we could see in the graph in the corner in the left. Next, please. Talking about the magnitude of the treatment abandonment in childhood cancer, we know that the population under 15 years, close to 90% lives in low and middle income country. And as you see here, close to the 85% of burden of childhood cancer cases are in low and middle income country. And when we talk about treatment abandonment, 99% occurs in lower and middle income countries, as you can see in this study. So that is a big issue in our region. Next, please. So we thought what could be the potential strategies and intervention to reduce the TRM. So some of them could be promoting early diagnosis, delivering effective care, early identification complication that PEWS and Proyecto EVAT have a strong space there. Also, improve PECU access or support. In some places, there is no PECU. And also, as you see, reducing treatment abandonment could be a potential strategy. Also, bundle for sepsis or infection. There is many opportunities to intervention. Next, please. Okay, I think it's Asya. It's for you.
So it's me. Thanks, Carlos.
Yeah. Welcome.
So why, if we have means to treat pediatric oncology, why aren't they used more in hospitals? And next, we could be saving lives with what we already know. If we could get them implemented and reduce the barriers to adoption. Next slide. So that is where I come in. I specialize in a field called implementation science, which is, next please, which is dedicated, one more time, to solving implementation problems. And what we do is we create generalizable knowledge about how to close the research to practice gap. It's often cited that it takes 17 years for what we develop in research to be widely implemented in practice. And what a lot of people don't add to that is it's actually only 14% of research, which is actually a very poor investment for what we know. And part of the problem and why this is practice is messy and variable. And so within implementation science, we spend a lot of time thinking about how to account for the variability in context that we see in practice, and while still maintaining the integrity of an intervention so that it continues to work. Next slide. So to break down how we think about this process a little more specifically, I like to use the this discovery to public health impact pipeline, which really characterizes how I think about this problem. We start with scientific innovation all the way on the left. We disseminate or attempt to disseminate that knowledge to a number of stakeholders at different levels within the healthcare system who are responsible for integrating new things into practice. Then we actually have to get it integrated, and then we have to maintain it. And there are problems at absolutely every point in this problem that leads to innovation not being used. But where we're really focusing our work and our attention is on the sustainability portion of this pipeline. Next, thanks. So I'm just going to define two words quickly that I'm going to use somewhat interchangeably, but aren't exactly the same. When I say sustainability, I mean the ability to maintain a program or an intervention, it and its benefits over time. So not just maintaining a program, but also all the stuff that you need to be able to do that. And then when I use the word sustainment, I mean more like a yes or no. The problem is that the program is there or it's not. And it's more of an operational definition that you would employ, like if you were trying to measure sustainment in a research like study like we intend to do. So why even bother with sustainability if we're having enough trouble as it is in the earlier part of that pipeline, like I mentioned? And I would argue that sustainability is the most important part of the pipeline because it's a lot of work to get new things up and running. And if we don't consider the long-term sustainment and sustainability of our interventions, you're not going to ever have the maximal benefit or reach the maximal potential of that intervention, which is really important in cancer control and treatment until what I assume is going to till a consistent set of cures are discovered for cancer. And so it's not going away anytime soon. And particularly for low resource settings or resource limited settings, like I said, it's a lot of work and it can be extremely expensive to treat cancer, and including pediatric cancer. And not just in terms of like dollars, but also investing people's time in doing new interventions, getting them the training, making sure that they're competent and can effectively use those interventions. And lastly, I would say sustainability is important, especially when you consider the equity implications of healthcare. We know that as Carlos just artfully articulated, that the burden is of pediatric oncology patients are in low resource settings. And so there's some really great evidence out there demonstrating that when you're inconsistent in your program delivery, you damage your trust in your relationship with the community. So you want to make sure that when you are considering something new, that you're going to be able to provide it consistently so that you maintain that trust in that relationship with your community. Next slide. However, the evidence on whether or not interventions are sustained is pretty bad. We know that after just 1 year of implementation, only 40 to 60% of programs are sustained. And that's even when you define sustainment rather loosely, as in just some element of it is still there. If you're talking about an entire program from top to bottom, the statistics are even worse. And yet sustainability is the least studied aspect of intervention implementation. And what do we expect to see? So we have a little bit of theory that my group has worked to establish called the clinical capacity for sustainability model. And this is the big circle that you see on the right, which characterizes the things that you need to be able to sustain an intervention. But I will say in general, there's lots of models out there, and they may have slightly different things that they feel like you need, or package them, characterize them slightly differently. But the general relationships that I'm going to talk about are generally the same. And it is that organizations must have enough capacity or resources to sustain an intervention. And it consists of multiple things that I won't go through each of these today because there's not time, but if you're interested, I'm happy to share papers that go into this into like phenomenal detail. And at the start of the intervention, you have to have a certain amount of capacity to implement that intervention. That amount may change over time, or you may adapt an intervention to better fit with the capacity that you have. But ultimately, you have to have a certain amount, or else you're not going to be able to sustain that intervention. And ultimately, that leads to good, improved, even patient outcomes over time. Next slide. So while we hypothesize and theorize that these are the relationships that are important and critical, there's actually very little empirical evidence demonstrating these relationships. So, and how can we promote sustainment of effective interventions if we don't even know if these relationships are necessarily true, even though we're fairly certain that they are, or fairly confident that we're, I guess, at the very least, hopeful that they are true. And just to illustrate how little we know about this, study by the National Cancer Institute noted that among implementation-related projects, very few focused on prevention, or very few focused on treatment, excuse me. The majority focused on prevention and screening. Most of pediatric oncology research is done in high-income countries, so we know that we're going to have a real implementation problem within our field that we're working in. And so let's say hypothetically, most of it was focused on treatment and most of it was done in low-income countries. We have almost no evidence-informed approaches to promoting intervention sustainability across any healthcare field, not just cancer. And even so, almost none of them have been tested in low resource settings. So there are multiple ways that the science is lacking, and we're hoping to address some of that with the particular evidence-based intervention that Asya's team and Carlos's team have worked for many, many years now to get up and running. With that, I'll hand it over to Asya to explain a little more about what that is.
Thanks, Ginger. So we'll try to apply this theory to a specific example of one evidence-based intervention. And so that's Pediatric Early Warning Systems, or PEWS. These are quality improvement systems that improve early identification of clinical deterioration in hospitalized children. And you can think of them as an evidence-based intervention to prevent treatment-related mortality in children with cancer. So the system itself has two components. The first is a scoring tool that's based on a patient's vital signs and physical exam findings. That's typically calculated by the bedside nurse with every set of vital signs in a hospitalized patient. That scoring tool will give you a number, but the team needs to know what to do with that number. So the tool has to be associated with an action algorithm that guides the clinical team in what to do for a patient with deterioration. The algorithms themselves are adapted to the local setting, but typically have this outline of a stoplight, with green being a stable patient, yellow a patient with deterioration, and red one at risk for critical illness. And as a patient moves through green to yellow to red, you're going to increase the frequency of assessment, including vital signs and calculating PEWS, get the medical team involved, and usually for a red patient, that involves an ICU consultation if an ICU is available. So PEWS are pretty ubiquitously used in hospitals that care for children in high resource settings. But prior to our work, were very underutilized in resource limited settings. And that's where we first started working on this problem in 2013, partnering with a pediatric oncology hospital called UNOP in Guatemala to develop EVAT, which is Escala de Valoración de Alerta Temprana. It's a PEWS that is translated to Spanish and subsequently had been validated to identify clinical deterioration in children with cancer in low resource hospitals in Latin America. And so this EVAT is a PEWS. It works just like in the way that I described. And the idea is that every hospitalized child with cancer will have EVAT or PEWS calculated with every set of vital signs as part of their routine care. If those results are normal or green, they're going to continue routine care, which includes assessing the patient with the baseline frequency. But if the results are abnormal, yellow or red, they're going to follow that action algorithm that includes a medical assessment. So since EVAT was first implemented at UNOP in 2014, we've done a lot of work studying the impact of PEWS implementation across multiple levels of care. And this figure summarizes that data. There's many studies that informed this model, not only from UNOP, but also from high resource hospitals like our hospital at St. Jude, as well as other centers in Latin America. And we can describe the impact of PEWS implementation across these 4 domains at the level of the patient, the provider, the medical team, and the institution. So for example, at the level of the patient, we have shown that PEWS implementation reduces the frequency of clinical deterioration in hospitalized children with cancer. It also improves communication between the family and the medical team. At the level of the provider, providers experience a lot of negative emotions when they take care of children with cancer. And that those negative emotions can lead to burnout and staff turnover, which are major issues in the region. However, using PEWS as part of the quality system in the hospital gives confidence to providers, and that is important to help them feel more positively around these acute events. Moving to the level of the medical team, PEWS involves communication between medical providers around patients with deterioration, and our work has shown that PEWS improves interdisciplinary communication and teamwork in these settings. And finally, at the level of the institution, PEWS has multiple benefits at the level of the institution in terms of their position and external support for patient safety, but also results in cost savings because clinical deterioration events and critical illness is costly. Preventing that is actually carries a significant cost savings for institutions. So with that preliminary data showing that PEWS are effective interventions on multiple levels to improve outcomes for childhood cancer, in 2017, we partnered with regional stakeholders to start Project EVAT, which is a multi-center quality improvement collaborative to improve outcomes for hospitalized children with cancer who develop critical illness through implementation of PEWS. And since 2017, we've had new cohorts joining the program every year. As of last year, we grew to 80 centers in 20 countries, and we just recruited the next 20 centers for 2023. So we now have 100 centers participating in this initiative in Latin America. So how does Proyecto EVAT support PEWS implementation? We think of this as a regional scale-up strategy using a multifactorial implementation strategy. So I'll describe that briefly through this wheel. If you start at the purple, you can follow along. For every center that joins Proyecto EVAT, they're mentored to develop systems to track clinical deterioration events in their setting as a baseline to identify the problem of deterioration. They then will work with a multidisciplinary team to adapt the typical PEWS that I described to their local setting and their resources. They'll be mentored to proactively assess potential barriers to PEWS use and then develop a plan that would address those barriers. They will then pilot and finally implement PEWS in their setting. During that time, they're going to monitor PEWS use to make sure they're using it correctly with high fidelity, and also evaluate the impact on patient and provider outcomes. And finally, of course, we want to not only implement, as Dr. McKay mentioned, but we want to sustain PEWS. And so that involves planning for sustainability. And so over the last 5 years now, we've had a lot of progress in PEWS implementation in the region. So through Proyecto EVAT, we've supported successful implementation of PEWS in 51 centers in the region. The remaining centers are in the implementation process that I described. Those centers account for over 16,000 nurses and physicians who have been trained in PEWS use in their settings. And since implementation, over 300,000 patient days have benefited from PEWS use in their care. These are just some photos from our collaborators showing how they use PEWS in routine care. And we've also been able to show the impact of this initiative on clinical outcomes. So this is a paper published by our team in Lancet Oncology just in July, showing the impact of PEWS implementation at 32 centers in 11 countries in Latin America that implemented PEWS between 2017 and 2021. Among those centers, they documented over 2,000 deterioration events across 556,000 inpatient days. And as was highlighted by Dr. Acuña earlier in the talk, unfortunately, mortality among clinical deterioration in children with cancer is very high. So across this cohort, 33% of children who experienced deterioration died during that deterioration event. So this is a big problem that we can address. So comparing the time before and after PEWS implementation at each of these centers, we showed that PEWS implementation led to 18% reduction in clinical deterioration event mortality rate in these centers. There was also a reduction in the use of ICU interventions and cardiopulmonary arrest outside of the wards, as well as the severity of illness and ICU transfer in the centers that had ICUs. And all of this was accomplished without an increase in use of ICU resources, which is important for resource-limited settings. Because this study included 32 centers, we were also able to look at center characteristics that impacted the magnitude of benefit from PEWS across these centers. Importantly, when we looked at center characteristics, we showed that PEWS had the same impact on centers that had different resource levels, nurse to patient ratios on the wards, the size of their pediatric oncology service, or country income level, which highlights that PEWS is really an effective intervention across centers of varying resource levels. However, comparing centers, we showed that the PEWS impact on mortality was greatest at centers that had the highest deterioration mortality rate prior to PEWS implementation. This highlights PEWS as a potential intervention to reduce disparities in outcomes, highlighted by Dr. Acuña earlier, because the centers that benefited the most from PEWS implementation were the ones with the highest mortality before. And then also, the effect on deterioration mortality was highest in centers that had the fewest omission in PEWS use post-implementation. Omissions are a way that our team describes documented vital signs without PEWS, suggesting a lack of using PEWS within patient care. And this point highlights really the importance of sustainability, because if you have PEWS omissions, that means you are not fully sustaining this intervention post-implementation. And importantly, what this study showed is that the centers that were having more omissions had less impact of PEWS on patient outcomes, which is, of course, what we ultimately want. And so although this study demonstrated PEWS to be a really effective intervention to reduce mortality in these settings that was most effective in centers that most needed it, it also highlighted the challenge of sustainability. And this mirrors qualitative work that was done by our teams previously, demonstrating provider perspectives on some challenges sustaining PEWS across centers participating in Proyecto EVAT. And these challenges or determinants of PEWS sustainability here are highlighted in blue. And as you can see, these challenges map well to the clinical capacity for sustainability framework described by Dr. McKay earlier. For example, some determinants of PEWS sustainability in these centers included having supportive leadership that encouraged ongoing PEWS use, and having beneficial patient outcomes that enhance the perceived value of PEWS among staff that would encourage their ongoing use. One external factor that we found in this study that I think many of you have experienced that impacted PEWS sustainability was the COVID pandemic. Beyond just identifying potential determinants of sustainability, one of the things we saw in this study is that there were multiple spontaneous potential strategies at these centers that they developed in order to promote sustainability. And this is really the highlight of what we are now working on in understanding in our current work. And so this is the recently funded R37, focusing on predicting sustainability of PEWS in low resource settings. And this is the INSPIRE grant, investigar sostenibilidad para instituciones de recursos limitados con EVAT, or investigating sustainability for institutions, resource limited institutions with EVAT. So here we want to focus on this concept highlighted by Dr. McKay, which is the clinical capacity for sustainability, which again is the capacity of an organization to maintain structured practices over time. And our work really wants to answer this question of what are the relevant components of capacity that determine PEWS sustainability at resource-limited hospitals, and then leverage that knowledge to develop sustainability strategies that are resource sensitive. So specifically, these are the aims of our work and the rest of our COI team. Over the course of this study, we want to answer these three questions. The first is, how does clinical capacity for sustainability change over time through the phases of PEWS adoption, implementation, and sustainability? We also want to understand how these changes in clinical capacity predict ongoing PEWS use or PEWS sustainment, and then the lasting impact on patient outcomes or a continued reduction in clinical deterioration event mortality rates. And then finally, we want to use the knowledge gained through this work, supplemented with qualitative data, to develop some potential strategies that would address these challenges to sustainability and promote sustainability of PEWS in these settings. And as this is an R37, we hope then to use that knowledge to potentially pilot some of those sustainability strategies in the last 2 years of this award. In terms of a little bit about the plans for data collection, and then I hope in a future meeting we could show you outcomes. This is a prospective observational study design that uses quantitative and qualitative data. For the quantitative data, we have a validated survey that assesses clinical capacity for sustainability that has been integrated into Proyecto EVAT since 2020. We also will be assessing ongoing PEWS use through review of medical records at participating centers, and using the same prospective clinical deterioration quality improvement registry to assess clinical deterioration event mortality, which is our patient outcome. And then for qualitative data, this will be supplemented with focus groups at 8 high and low capacity hospitals through the course of this study. We're going to be speaking with nurses, physicians, and administrators, trying to really explore those key determinants of sustainability and develop some potential solutions or strategies for sustainability. So in summary, hopefully we've shown you that treatment-related mortality is a significant problem. It accounts for 1/3 of childhood cancer deaths after starting treatment in low middle income countries, and disparities in treatment-related mortalities are widening over time. That PEWS are effective cost-saving interventions that reduce treatment-related mortality in low resource settings, and they have multi-level benefits for patients, providers, medical teams, and institutions, and are effective in hospitals of all resource levels. However, the impact of PEWS depends on an adaptable implementation strategy and planning for sustainability. This is the focus of our work. And this work in general is an example of how implementation science can, and we think should, be used to reduce global disparities in childhood cancer outcomes. So with that, we're going to end. I want to leave a little bit of information about our 2 programs. So Dr. McKay is part of the Center for Public Health System Science at the Brown School, and a lot of the work that has been done with the tool to assess clinical capacity for sustainability, or the CSAT, is publicly available on their website at thesustaintool.org. And then I lead our global critical care program at St. Jude, which aims to strengthen care for critically ill children with cancer throughout the world. And this program does many things, including oversee Proyecto EVAT. And so if this is an area that's interesting to you, you can email us or scan this QR code to join our program. And so with that, I'm going to end. This is our research team and our contact info, and I think we'll be happy to take questions.
Thank you, Dr. Agulnik, Dr. Acuña, and Dr. McKay for a terrific presentation. We'll now open the session for questions. We invite you to turn on your cameras if you're comfortable. As a reminder, you may type your question in the chat box or use the raise hand feature found under the reactions and wait to be called on. When called on, please unmute yourself and ask your question. And we'll get to as many questions as we can during the time. And I've left 20 minutes for questions, so it's a nice amount of time. I'll take the prerogative of asking the first question. Where are you in the process of implementing the program in South America? Your program, the latest one, R37.
Yeah, so I can start with that, and maybe Carlos can add a little bit on the perspective from the Regional Steering Committee. So one of the things I didn't speak a lot about is the role of our regional stakeholders in overseeing Proyecto EVAT. So we have a 33-member steering committee of multidisciplinary clinicians from the region, of which Carlos is the representative for this work. And as I mentioned, we, with the oversight of the steering committee, have integrated assessment of clinical capacity for sustainability into the implementation process since 2020. And since this grant was funded in April, what we've done is then extend that work to sustainability centers. So centers that are sustaining PEWS post the period of where we oversee them through Proyecto EVAT. Which includes centers that have been sustaining PEWS up to 10 years. And so we have piloted some of the data collection for that in April, and we'll have our first real data collection time point in October. And we've done a lot of work with the steering committee to work through the best way to do that, and also to communicate the need for this work to centers, and have had actually a very positive response from all of our collaborators. So the goal for this grant is to have about 90 centers over the course of the study participate. We have 100 centers now in Proyecto EVAT, so we're confident that we're going to reach that through the 5 years. And I don't know, Carlos, if you want to talk a little bit about the regional perspective on the importance of this work.
Thank you, Asya. Thank you for the question. Yeah, as you say, we are ready to go now. In October and November will be the first data collection. Probably the center in Latin America, we are doing reinforcement of the PEWS EVAT, and we are talking with all the components of our team, like nurses, doctors, and fellows. And I think through the process, we are ready to start and see what happens. I think is clue for the project reinforce this aspect. So it's a nice project.
Lydia.
Thanks, Marie. Asya, Carlos, and Virginia, great work. Thank you for sharing. I first of all wanted to congratulate you. And I've been following the PEWS work since we funded the Burkitt lymphoma grant in 2017. And so I've been following how far this has come, and from its stage of development and to now where it's in the stage of implementation. It always makes us extremely happy to see our early investment coming to the stage of implementation. So I just wanted to congratulate all of you on that. Just quickly, can you tell me your plans for monitoring and evaluating your sustainment on a long-term basis within the communities. And thanks.
Yeah, absolutely. So I mentioned in the implementation process, we already integrate assessments of the quality of PEWS use. And that's because we believe that you have to use the intervention correctly in order for it to have benefits. And that is the way that we measure that is we describe 3 types of errors in PEWS use. So those errors are PEWS omissions, which I highlighted in my talk, which is documented vital signs without a documented PEWS. The second type of error is a calculation error. So the PEWS is calculated based on the vital signs. Those are age adjusted. So if you're miscategorizing vital signs, that would be a calculation error. And then finally, an algorithm error, meaning you're not escalating care appropriately for a patient who has an abnormal PEWS. And through the implementation process, all centers actually measure those errors, types of errors, a few times a week, and then we'll aggregate that monthly. And we expect for a center to be considered to have completed PEWS implementation for the sake of the collaborative. They need to have less than 15% of those errors for 2 months. And so that's the same threshold that we use as our sustainment measure. So our measure of PEWS sustainment will be the same, looking at those 3 types of measures quantitatively, so the percent errors, and then for that yes, no sustainment measure that Dr. McKay mentioned will be whether they are or not above or below the 15%. And as you saw that in our outcomes paper, we were able to show that PEWS omissions in particular are really related to sustained impact on outcomes. And so that's one of the things we're going to be paying close attention to.
But I'd love to add to this. I think one of the ongoing sustainability debates that we're interested in speaking to with this is, is the 15% the right marker? And is it, should it really be like 20% or should it be 10%? And because it is an artificial threshold, and I think we're excited to be able to explore that issue in a way that previously very few people, like I keep harping on, even outside of pediatric oncology, have been able to explore.
Thanks, Virginia. I think that's a great, important point to note, because I think that's something the global health community is struggling and in defining what that threshold is. Thanks for noting that.
Marie, can I ask a question?
Yeah, I was muted. Satish.
Thank you all for a great talk. I think this is a question really to all of you. I'm curious if you have a sense and/or are capturing the degree to which your PEWS-focused intervention may be having effects on other aspects of their cancer care, in particular their cancer treatment. I could imagine that some of the organizational changes that are occurring might also lead to greater protocol concordance and adherence. And I ask because I worked mostly in Africa before coming, and we really focused a lot on diagnosis and treatment because that was really our critical need. And we had the sense that it had some downstream effects on supportive care, although I think we weren't smart enough, frankly, to capture those meaningfully. So I'm wondering if you're looking at some of those kind of collateral off-target effects of your intervention. Thanks so much.
Yeah, it's a really good question. And we actually think not only on the impact of implementing one intervention on other components of care, but the impact of implementing an intervention within childhood cancer care in a multidisciplinary hospital that cares for other types of patients. And so I think we've had lots of qualitative data that supports this point, that there are benefits that expand beyond the immediate impact. And so what are those benefits? So some of the things that we've shown in our research, and I actually want Carlos to talk about as a center who has implemented PEWS for some time, what he's observed. But in our multi-center qualitative work, what we've shown is really a heightened attention to patient safety beyond just this one intervention, but then across other levels of care. Empowerment of the medical team to be able to actually implement change, because this is a complex multi-system intervention But centers that successfully implement this, they see the impact on patient care and are empowered to then think about what other elements of care they can address through other safety interventions. We teach a lot of quality improvement methodology through the collaborative. And so that, of course, can extend that those skills can be used to make other quality improvement changes within the centers. And then importantly, because most childhood cancer care is not provided in a vacuum, it's provided within a different health system, and that could be a system that treats adult cancers or one that treats other pediatric diseases. We've seen centers implement PEWS within their pediatric oncology unit, but then actually expand PEWS or similar programs to other units. So those are all different ways where success within one intervention can actually have impacts that are beyond that one area. Now, we have not had great success in thinking of how to quantitatively measure this, but we do have a breadth of qualitative data that supports this. Carlos, do you want to talk a little bit about your experience with this in Calvo, which is a multidisciplinary pediatric hospital, not just an oncology hospital?
Yes, sure. Yeah, great question also. And I think the clue is the PEWS EVAT is a quality improvement program. So that allows a center like us or in another countries in Latin America to improve the way that we work. So that impacts in treatment-related mortality, the way that we take care of our patient. And you can see the impact in centers that have a little low, a big low resources. And they, when we talk with us, you can see that they change the way that they take care of the patient. So that clear impact sometimes is not easy to measure that, but at this, I think that the big quality of this program that for sure impact in many aspects of the care of the patient, oncology patient or general pediatric patient.
Patty? Patty?
Patty.
She's frozen. Does anybody else have any questions till Patty's able to rejoin?
Okay.
I think Geraldina has one.
Yeah, sorry, I used the wrong hand. Very, very interesting and really not my area of expertise. But I was wondering whether something like this could be extended not just to Latin America, because to places like Sub-Saharan Africa, where it really things are, for pediatric cancer treatment is really a significant burden, and as to something like this, could it be done?
Yeah, so it's something that we're working on as part of the bigger program in global critical care. It's really getting at this concept of scale up, and Proyecto EVAT is a very effective strategy to scale up regionally. But as you think about scaling outside of the region, there's obviously lots of different contextual factors that would impact what is the appropriate strategy for how to scale up an intervention like PEWS. And then also whether the intervention itself needs to be adapted to work within a different healthcare setting. And so we started some of that work, and it's something that I really hope to explore more going forward. We have now the second year of a pilot of a program called PASHA, which is PEWS adaptation to support hospitals in the Alliance, our global alliance. And that initially included 5 centers in Africa and Asia. And this year, after we learned a lot of things from that initial pilot, 7 new centers. We're still, I think, working through the adaptation of our implementation strategy. to be effective to promote implementation and sustainment of PEWS in those settings. It's very much a work in progress, but it's a need because, you know, our work has shown that this is an effective intervention to reduce treatment-related mortality, and it's most effective in centers that need it most. So there's a global imperative to scale up this intervention. What we're trying to understand is how to do that most effectively. And it's just as Dr. McKay highlighted, the field is really lacking in research around sustainability. There's also a huge gap in understanding strategies for scale up, especially across different contexts and resource levels. And so that's something that I think will be a focus of our work going forward. And I don't know, Ginger, if you had more thoughts on that.
Oh, I was just going to say that we're doing it though with the help of implementation science. That was my only addition.
Yeah, and I think
Vidya.
that's important because what we want is that the work we do in PEWS to be generalizable to other interventions in other settings. This is one intervention, but obviously it's not going to solve all of the problems of delivering childhood cancer care in low middle income countries, but we can learn a lot from this work in order to improve implementation, sustainability, and scale up of other interventions.
Yeah, and sustainability is the area least represented in implementation science. So, Vidya, did you have a question?
Yeah, if we have a few minutes, but Asya and team, it would be nice to hear what are some of the, other sustainment interventions you did in terms of like, capacity or getting this across to your, at least for the project, in the piloting stage. And because I feel like at least with the earlier work around PEWS, there was a lot of applying the same protocol across different sites. There was an issue with uptake and reach of that. So I'm just curious what additional systems went into place to make sure that this was sustainable.
Well, I remember a few, and then Asya can jump in with the ones that I'm forgetting. I do think one of the ways was to allow parents to do some of the assessment if nurses weren't able to come through at regular intervals. Another one, because a constant issue for sustainability across, regardless of the intervention, of staff turnover. So you train people and then they leave and go somewhere else, was on their own. Some of the institutions put into place resources, training programs, so that as new nurses came on board, that they were able to get up and running in PEWS. I think Asya helped me with this one. There were some also institutional level ones of
so an example of one of the things that was very important across centers is leadership buy-in, and leadership turns over as well in many of these centers. And so successful centers would have strategies to kind of reintegrate new leadership into the importance of PEWS, showing center-specific data of impact to have ongoing leadership support and resources for PEWS use. I think that staff turnover thing is, as Ginger said, that seems almost ubiquitous, and I think it's probably only worsened since the pandemic. And so having ingrained systems for how to onboard new staff into PEWS as part of the institutional culture rather than an additional thing that you're doing. There's some others too. I think one of the challenges that centers seem to face is changes in resources and hospital structure after PEWS implementation. That would require adapting the way that they use PEWS in patient care, and whether those adaptations happened systematically or not, sometimes impacts what happens with the program. And that's one of the things that we're hoping to explore more as we do this work.
And so I think innovation, like people coming up with their own strategies in practice, are really great. And we hope to, consider some of these and help put evidence behind them. but also then consider things that perhaps folks had not have come up with yet as well.
With that, this concludes our session today. Thank you so much, Dr. Agulnik, Dr. Acuña, and Dr. McKay for joining us. Please remember to join us for the October session with Dr. Laura Fetterman, who will present on the genetics of breast cancer in women of Latin American heritage. And once again, please visit our website, cancer.gov Global Health, to find information about upcoming sessions, past recorded sessions, funding opportunities, events, news, and more. And follow us on Twitter at NCI Global Health. Thank you.
Thank you.
Thank you.